In this video series, clinical experts and WTR advisors discuss modern approaches to treating specific tumor types. Joining us for this video is Dr. Maria Cabanillas, WTR Clinical and Oncologic Endocrinology Advisor.
Hello, my name is Maria Cabanillas. I'm going to present the management of nonBRAF mutated anaplastic thyroid cancer. Most important thing to know about these patients is that they're very high risk of dying from their disease, and therefore all of them are stage 4. We then classify these into stage 4A, stage 4B, and stage 4C. Stage 4A patients are patients that have intrathyroidal disease, and usually these are resectable. They can be removed. Stage 4B patients have extrathyroidal disease, or they have lymph nodes that are involved. And then stage 4C patients have disease that has spread now and developed metastatic disease, and that's about half of our patients when they present. Now, it's important to understand the stage because this will dictate what the treatment will be. Other important pieces of information are to know the BRAF status. Patients who have a BRAF V600E have very good therapies now, very good targeted therapies. And so we need to distinguish between these two patient types. We need to also make sure that the airway is stable, determine whether the tumor can be removed, the primary tumor. We have to confirm the diagnosis and have a goals of care discussion. On the right here, I show the imaging that is necessary to really understand the best management for these patients. And then also the mutational testing. And I'll point out that there are expedited ways of determining the BRAF status, which should be used initially, and then a complete analysis of the tumor can be done, which usually takes several weeks. We don't want to delay knowing the BRAF status by just sending one of these NGS tests that take longer. So let's start with patients who have stage 4B. These patients do not have metastatic disease. The American Thyroid Association guidelines are very clear about this. The patient is either resectable or not. If they are not resectable, then they go straight to chemoradiation. If they are resectable, then they should have upfront surgery followed by chemoradiation. Now, the chemotherapy, radiosensitizing chemotherapy, the radiation is about a 6-week course of radiation, so fairly long. Now, the recommendation currently is to observe these patients once they're done with this therapy. However, the relapse rates are very, very high. And therefore, we recommend adding adjuvant pembrolizumab. This will slowly make it into the guidelines, the various guidelines. Usually pembrolizumab is given for 1 to 2 years. And it started between 4 to 6 weeks after completion of radiation, or within 4 to 6 weeks. The reason for that is that there are patients that relapse very early, and therefore we want to initiate the treatment before that happens. So the data based on this study with adjuvant pembrolizumab, and this was a study where we took prospective clinical trial patients and we pooled the data with retrospective patients. Because the study was open during the pandemic, we were unable to fully enroll the study. Patients didn't want to travel. Now, we then compared it to a control arm, which was a retrospective control arm who had never received adjuvant pembrolizumab, and these were age-matched patients. These are the results. In blue are the patients who received the adjuvant pembrolizumab, and in red color are the historical patients that did not. So all of these patients had upfront either surgery, radiation, or radiation, and they were age and treatment matched controls. So you see that there was a 19% relapse rate in the patients treated with adjuvant pembrolizumab, but 82% in the matched controls. And the median overall survival had not been reached in the adjuvant patients, but was 5.4 months in the patients who did not receive adjuvant pembrolizumab. All right, so stage 4C patients that do not have a BRAF mutation, we have tried single agent drugs, several single agent drugs. I'm only showing you the lenvatinib data. but the data really don't support using single agent kinase inhibitors in these patients. We saw a median overall survival of only 3.2 months, and therefore the trial closed early. But you do see a signal here. So there are patients that do have tumor shrinkage. And so the question is, can we add something to improve the overall survival rate? And the answer is yes. So we now combine lenvatinib with pembrolizumab. There are two studies that support this. One is the study from a German group, and then study from the MD Anderson group. So the ATLAS trial, this is the German trial, showed an overall response rate very high, 52%. The MD Anderson trial was lower at 38%, but 68% of our patients started a reduced dose of lenvatinib in order to minimize fatal side effects, which I'll talk about in a moment. The median overall survival, however, was about the same in both studies, approximately 11 months. And this is already in the NCCN guidelines, pembrolizumab with lenvatinib. This is the treatment-related adverse event profile for lenvatinib and for potent anti-angiogenic drugs. And what I want to point out is that fistulas and airway bleeding are often fatal, and therefore we need to be aware of these possibilities with these powerful anti-angiogenic drugs. In the ATLAS trial, the fistula and arterial hemorrhage rate were 11% for both. In the MD Anderson trial, it were 8% for both. So they had 4 for each, and we had 2 for each. So this could have been because we used lower doses. So our current approach for patients who do not have a BRAF mutation and who have 4C disease is to first start with palliative radiation. The rationale for doing that, and only if you can do this quickly, the rationale for doing that is that we don't want to put a patient through 6 weeks of radiation if we're doing like IMRT to the neck, because the distant metastatic disease will start to grow and we'll lose control of that, and the patient may not then be well enough for therapy. Therefore, we use a shortened course of radiation, which we give over a 2-day period called quad shot, and then we introduce the other drugs. The other reason why we like to give palliative radiation is because we believe that it will improve the ability of the immune system to recognize the tumor as needing to be eradicated. So we do start with palliative radiation at our institution, and we add in the other drugs. If we can take the patient to surgery, certainly do that. Another treatment that can be given to patients, a combination of anti-CTLA-4 drugs such as ipilimumab with the anti-PD-1 drug, which is nivolumab. This combination we call IO-IO for immunotherapy combination. And this is a very small study from a single site. There were 10 patients with anaplastic thyroid cancer. The response rate in these patients was 30%, 50% of patients deriving clinical benefit. After a median follow-up of 22 months, the median overall survival had not been reached. And what's really interesting is that the curve starts to flatten. What does the flattened curve mean? It means that no more patients are dying. And so this is an exciting combination for anaplastic thyroid cancer. I will note that 90% of patients had prior thyroid surgery, and therefore, their airway was probably stable. So we always have to think about airway stability before we proceed. But again, you could also do the palliative radiation prior to introducing these drugs in stage 4C patients. So in summary, this is our current management of non-BRAF mutated anaplastic thyroid cancer. We need to do a good initial workup, including BRAF analysis, staging, and whether the patient can go to surgery or not, especially in stage 4B patients. This should then be followed by an evaluation for the possibility of giving palliative radiation to 4C patients, and then giving them a combination therapy with either a targeted therapy plus immunotherapy or dual immunotherapy, the IO-IO combination. Patients can then be evaluated for surgery and radiation and then put on maintenance therapy, meaning that they just continue these drugs for an indeterminate amount of time. And we're still studying that at the moment. So this is a little chart that also includes what to do with the BRAF mutated, but this is essentially just to put all of the data together for you. Okay, so it's great that we have all these drugs, but not every country has the ability to access these drugs. And therefore, what we recommend for stage 4B patients without BRAF mutation, or if the status is unknown, is that they undergo surgery if possible, and then undergo chemoradiation. If they can't have surgery, then they go straight to chemoradiation, and then you observe. For stage 4C patients, if they have a good performance status and they wish aggressive therapy, then our recommendation would be to initiate carboplatin pemetrexed. Probably if you can give upfront palliative dose of radiation, that would be ideal. But again, not everybody has access to these modalities. So that's all I have for you today. Thank you so much for listening.